Welcome to the official launch of the Verse Equity Toolkit for multidimensional equity assessments. This webinar will be recorded and will be available for viewing after today's presentation. Thank you very much for attending. I will give you also some information about a post-webinar folio that you can take with you. And that will contain all the resources you need to continue any work with the Verse tool if you wanted to use it to perform equity assessments. Before we get started, I want to let all of you, all the participants know that we will have a Q&A session at the very end. So please use the Q&A function inside the webinar, inside Zoom, to ask your questions. Our team will do our best to answer what we can in writing or to collect your question to make sure they are answered live. We would love also to have you introduce yourself in the chat, the Zoom chat. Make sure you do not post questions there because we may not monitor it as much as the Q&A, but we would love to hear from you. And before we introduce the different speakers for this session, I would like to do a little poll. I would like to break the ice and make sure that we make this presentation as relevant as possible for you in your area of work and your organization. So I am going to launch a poll which will ask you what type of institution or company you work with. Please fill it out, and before we see the results, I'll share it with everyone afterwards. I would like to introduce our speakers for today. So the first speaker is Dr. Bryan Patenaude, health economist and assistant professor in economic evaluation at Johns Hopkins University, the Bloomberg School of Public Health in the Department of International Health. At IVAC, Bryan is the principal investigator for the fourth iteration of the Decade of Vaccine Economics, otherwise known as the DOVE project. The DOVE project sought to quantify the economic cost of illness associated with vaccine-preventable diseases and quantify the return on investment of vaccines globally. Bryan's other work focuses on assessing the strength, sustainability, and efficiency of health financing in low and lower middle income countries, applying behavioral economics to the evaluation of public health policy, designing contracts and incentive for an efficient health workforce, and understanding the medium and long-term causal impact of health investments on non-health sectors. Our second speaker for today is Dr. Elizabeth Ekirapa Kiracho, chair at Makerere University School of Public Health in Kampala, Uganda. She has worked for close to 12 years at the Makerere University. Prior to this, she worked in a rural hospital in Uganda, has specific training and expertise in key research area that includes health systems, health financing, performance-based financing, costing, economic evaluation, maternal and newborn health. Furthermore, she has been the principal investigator in several research projects that seek to better understand and influence the implementation process while demonstrating their impact on maternal and neonatal health in a robust way, based on integrated and realistic strategies that rely on local institutions and contexts and a reasonable cost base. And finally, our last speaker is Mr. Anthony Sebagereka, who is a research fellow at Makerere University School of Public Health. Anthony has a background in pharmacy with graduate training in health services research. Anthony has a wealth of experience in the design and conduct of operational and implementation research in the areas of global health, pharmaceutical supply chain, access to medicines, victimology, as well as support innovations in the area of resilience and development interventions. Most of his work in the recent past has focused on development research in the sectors of malaria, HIV/AIDS, tuberculosis, sexual and reproductive health, immunization, and neglected tropical diseases. So thank you very much to our speakers for joining today, and thank you all for filling this poll. I am going to end the poll and share the results with you, where a vast majority of the audience, 45%, comes from academic institutions. We have a good representation as well from government agencies, multilateral agencies, and non-governmental organizations. Fantastic. Well, we are eager to get started. So without further ado, I will give the floor to Dr. Bryan Patenaude.
Thanks, Gassian. Great. I will just make sure. So I'm going to give a high-level overview of the VERSE project and what we've been doing under it. So I'm, as Gassian said, Bryan Patenaude. I'm the PI of the VERSE project, which stands for Vaccine Economics Research for Sustainability and Equity. It's work funded by the Bill and Melinda Gates Foundation, and the goal is to explore and measure multidimensional equity in a way that's useful for assessing composite equity over time and space. So I'll lay out first how we're thinking about equity and how we measure it, and get into some of the specifics of what the VERSE tool and VERSE methodologies within the toolkit do. So we have a series of data that we can use to measure equity. And what we're trying to figure out is the difference between equity and equality for the purposes of our measurement. So you can see here we have data. This is our sort of framework for thinking about this. We want to make some kind of distributional assessment over our outcomes. So for example, for the purposes of this study, we'll focus on vaccination status. So whether or not a person is vaccinated. If the answer is yes, then we will record that and see why that case is. If the answer is no, we need to assess whether or not there was a need for that individual to be vaccinated. And so this is the linking of the tool to equity rather than just equality. We need to have some type of needs assessment for should, by the age that they are in the national immunization schedule context, should they be vaccinated? If no, they're left out of the analysis. If yes, they're included in the analysis. And so our equity assessment becomes the comparison between those who are vaccinated and not adjusting for fair and unfair factors. And so I'll talk about what unfair factors are in just a minute, but the fair factors of why someone shouldn't be vaccinated, and we'll use that terminology a bit throughout the course of the webinar, are the age of the child for the purposes of these pediatric vaccines. For other vaccines, they may be whether or not you're eligible. So for example, COVID-19 vaccine, whether you meet eligibility criteria. But for the purposes of this presentation, we'll talk about being of age in the national immunization schedule. And we use this literature, this word fair and unfair, to talk about determinants because it's linked with the theory of social choice. And what was laid out in terms of mapping determinants onto outcomes, and we'll talk about that a little bit later on. But we will continue to use that terminology throughout the presentation. So with that concept in mind, what we're thinking about in terms of equity within the VERSE toolkit is not just to examine across one dimension, which is typically done. So for example, you'll often see equity measures that rank people from poorest to wealthiest. So for instance, the Gini coefficient or the concentration index. And these take a look at equity across socioeconomic status. Other examples of these sort of one-dimensional versions of equity assessments include things like the gender gap or sex gap, equity over maternal education, health insurance coverage, or sex of the child. And what we're trying to do under the VERSE project and what we've done within the toolkit is combine these into an indicator that allows people to be mapped from most disadvantaged to most privileged. And this mapping allows one to take into account multiple different sources of inequity and combine them into one single measure. So you can see here some differences, and this is just a quick high-level results for examples. But if we compare sort of a standard concentration index, which is a measure of inequity that's commonly used in the health and in the income inequality space, and it takes into account the differences across the distribution of individuals and how far they are from achieving perfect equity or equality, if you're just taking a look at income over socioeconomic status, we can see that there are differences in what we get using a VERSE style measure where we take the composite index versus just a concentration index over wealth, which is very commonly used in the health space right now. So here's some examples from the most recent DHS Demographic and Health Survey data sets, taking a look at measles MCV1 vaccination coverage in Afghanistan, Bangladesh, India, and Uganda. And if you take a look at what you would get if you examine the distribution of MCV1 coverage over socioeconomic status based upon the asset index alone, you'd come up with a concentration index that for 3 of these 4 countries looks pro-poor and is pro-poor. And the takeaway message from that would be that equality is good, and actually these investments are going more towards the poor. However, if you take into account some of the multiple dimensions that we talked about, sex of the child, maternal education, all of these other things that may lead to disadvantage and may be masked by just examining wealth status, you can see that there is still persistent inequality and inequity that exists over MCV1 coverage in all of these countries. And so the CI composite that we have on the right is the metric, one of the metrics that is produced by the VERSE toolkit. So just a high-level overview of what the objectives and rationale for doing this type of work were to begin with. And our goal is to provide countries with robust evidence on the economic and equity implications of their immunization financing and delivery strategy, as well as an ability to track equity and progress towards achieving equity goals over time in a consistent way that's comparable across periods, within countries, across districts or states, and between countries. So that standardization aspect is very important and something that we've incorporated into this. So the primary components of the project overall are this vaccine equity assessment methodology and toolkit, as well as country case studies that take this toolkit and apply it to different scenarios and settings and data sets in order to inform policymaking and program evaluation. So our vaccine-related outcomes that we'll be taking a look at through this include programmatic outcomes like coverage. We can also take a look at economic outcomes, for instance, vaccine preventable disease-related costs and benefits, or cost of illness related to averted infections. And we can also take a look at health outcomes downstream if there's data available on that in a setting. So for instance, equity in the DALYs or QALYs accrued due to averted infections. And the toolkit properties contains a number of different components. So there's multidimensional equity assessment. So we take a look at primarily in the base case, socioeconomic status, urban-rural designation, region, geopolitical region typically, sex of the child, maternal education level, and health insurance coverage. But you'll see for some settings, we've added other things into that as well, and it's pretty flexible. Another property is that all of the metrics we produce are decomposable back into their component parts. So we can figure out how much of the observed inequality or inequity is due to the different types of things that make up the composite index. And finally, it's flexible. So it can utilize anything that's an individual level data set, or at a small enough level where you have sort of multiple communities in a data set or districts, it can utilize any data that is at that level. And just linking back to this sort of language about fair and unfair determinants, which you'll see there's a long literature of methodological development that this VERSE toolkit builds upon. And a lot of this comes from the social choice economic space, but also from the equity in health and equity in income space. And so we combine a lot of this terminology to link it with the theory, but also make some adaptations so it is specific for this purpose to the vaccine space. So the VERSE Equity Toolkit generates several key metrics. I talked about in general what they were, but for the purposes of this talk, we'll go into a little bit more detail about what actually comes out of this. And so the first is an efficiency metric or a progress metric, depending on how you want to think about it. Typically for vaccine outcomes, that's going to be vaccine coverage. So how many of the children in your data set have received the vaccine by the appropriate age in the National Immunization Schedule. There's also the ability to pull health outcome data. So for instance, if you want to examine equity in zero dose status, your efficiency metric would be zero dose prevalence. There's also the ability for other outcomes to add other types of efficiency metrics as desired, but those are sort of the standard ones for the health case that we'll be discussing today. Our equity metrics include several different variations of commonly utilized equity metrics, but utilizing the VERSE methodology and the methodology described by authors in the previous page to rank individuals by disadvantage rather than purely by one dimension of that disadvantage. But with that ranking, we can then compute indices that are sort of standard indices, which have very nice properties in terms of interpretation and measuring equity. So the first are a series of concentration index, which can be with or without the Erger's correction. And these are standard concentration indices that are interpreted in the same way as greater than larger values in the positive direction will be correlated or mean more inequality or inequity. The absolute equity gap is just the difference between the most disadvantaged quintile and the least advantaged quintiles, most advantaged and least advantaged quintiles. And this is meant to just give an absolute level difference between those two groups, but ranking people based on composite disadvantage. And then relative equity gap is the ratio between the most and least advantaged groups. Our slope index is a standard slope index that takes into account all of the groups that happen in between those, but is interpreted in the same way as the absolute equity gap, and the same for relative index of inequity, interpreted the same way as the relative equity gap. For this, we'll focus mostly on the concentration indices, but for policy purposes, often the absolute equity gap is particularly useful because it's easily translatable in terms of the outcome that you're measuring. And so here's some examples of, we can map within the toolkit. So you'll see in the demonstration that there's mapping that can be done with anything that's included in the DHS, at least. We have all the shape files and areas, so you can see things like vaccination coverage versus zero dose prevalence versus equity and mapping, and call those out of the toolkit. Another thing that's useful for that the toolkit produces are these equity coverage or equity efficiency trade-off planes, which showcase how different regions within a specific country perform relative to one another on both coverage and equity as measured in the manner of our toolkit. And so here's an example that comes from one of the demographic and health surveys from Uganda in 2016 on fully immunized for age. You can see different coverage levels in different regions of Uganda and how they compare in terms of coverage and equity, so that one could take a look at different areas that are achieving similar levels of equity or coverage and why they might be obtaining them in that way. So for instance, it might be nice to draw a line at about 60% right here, where you see regions 10, 7, and 14, and discuss why and examine why they're so different in terms of equity when they've been achieving the same levels of coverage. We can also track over time across the DHSs for these purposes, or other data sets that are measured in the same way over time, how different countries or regions within those countries are performing with respect to time. So here's an example, again, using Uganda from 2000 to 2016, utilizing all of the DHS data, showing the progress in both the equity and coverage dimensions over time. And finally, you can break this down subnationally. So all of our indicators that we've talked about so far, the concentration indices, the absolute equity gaps, they're all computable at the subnational level, so long as you have an individual level data set or very small subnational units. And so we can compute these and figure out how different regions within a country are performing with respect to time as well. So again, here's an example from Uganda, utilizing the DHS data over time. And our colleagues from Uganda who've worked on some of these analyses will talk more about their application of the tool later on in the webinar. But you can see here an example from the toolkit just utilizing the DHS data and showing how these different regions have changed over time. There's been some changes in how the data sets map regions. So you'll see 1 point from 2000 expanding into 2016, but you can see how each of these areas have progressed in terms of both coverage and equity over time with respect to full immunization. So that's the child has received all of the vaccinations that are required or suggested up until that age that they appear in the data set, dictated by the National Immunization Schedule. So we're going back to this unfair factor and quantifying the influence of unfair factors. And so again, this terminology comes from the sort of social choice space, but what we're considering unfair factors here are things that are preventing children from becoming vaccinated that really shouldn't have an influence in their vaccination status. And these things include whether or not they're covered in health insurance, the region where they were born, settings that they live in, so whether or not they're in an urban or rural and peri-urban setting, socioeconomic status of the household that they're born into, the sex of the child, and maternal education level. So these are sort of the things that we look at in the base case. For setting specifics, for example, India, we take a look at caste, and other settings can add different types of indicators that data are available on in order to break this composite equity metric down into things that are useful for policy. And so you can see what our toolkit produces as this graphic with a breakdown of percentages, how much each of these different factors comes into play when thinking about the equity metric that was computed. And these are done in sort of a traditional regression decomposition manner, breaking the concentration index produced by the verse ranking methodology into its component parts. So here you can see, for example, that Bangladesh DHS in 2017, if we're taking a look at fully immunized for age, the leading source of variation in that inequality and coverage of fully immunized status is maternal education level, which accounts for about 32.9% of the observed inequality or inequity in the outcome. And wealth quintile comes in second place with 27.2. And you can compute these for every different vaccine or different outcome for different types of settings and compare across settings, because again, all of these methods are standardized. So I just wanted to shout out to the core team and acknowledge our advisory group. So the core team consists of myself, Gastien de Brooker, who you heard earlier introducing, Joshua Mack, Celine Sriudamporn, and Deborah Odihi, who are all based at the Johns Hopkins University International Vaccine Access Center. And we have a core group which consists of members on an advisory committee who've given a lot of feedback onto the methodology and presentation of the toolkit in its early stages of development. And those include members from Gavi, the Vaccine Impact Modeling Consortium at Imperial College, Center for Health Equity, IHME, Results for Development, the WHO, and the Bill and Melinda Gates Foundation. So we're going to go over briefly some of the applications of the toolkit. And while we're going over some of those applications, I'll talk through some of the more specific components that are being presented there and how to interpret them. But we've applied the VERSE toolkit to a number of settings so far and are always looking for additional collaborations. So you'll hear a bit about that later. But one example is applying this in detail to the demographic and health survey conducted in Nigeria in 2018. With the goal of examining the determinants of inequity in zero dose status and fully immunized for age. The second is assessing equity in coverage for vaccines offered inside and outside the National Immunization Program in China, and that's in collaboration with Peking University. A third case study has been to estimate the economic burden of vaccine preventable disease and examine inequities in both economic burden and vaccine coverage across different settings in Bangladesh, so urban, peri-urban slum, and non-slum urban. The fourth is to examine inequities in maternal and child healthcare outcomes instead of just vaccination outcomes in Kalyani and Chandigarh in India. And the final case study that we'll go over the course of this webinar is adapting the VERSE Equity Toolkit to respond to health policy priorities and multi-agency feedback in Uganda. And that's with Makerere University. So for the DHS Nigeria project, you can see some of our collaborators here, including Dr. Daniel Ali and Chizoba Wanodi, who are both based at the International Vaccine Access Center as well, and have provided a lot of feedback from their experience in the Nigeria context. So here you can see some different outputs from the Nigeria DHS that are produced by the VERSE tool. So the first is a zero dose prevalence map showing which regions have the highest prevalence of zero dose status. The second is concentration indices to show which areas have the most inequality based upon measurable unfair determinants for being zero dose in that particular setting. And then the final piece is a decomposition of the zero dose inequity and sort of what we see as contributing the most towards that status. And you can see that overwhelmingly here, maternal education level being correlated or associated with that zero dose measurement and the inequality observed in zero dose measurement. And with other things, including urban, rural, or wealth quintile, contributing a much, much smaller amount to what we're viewing with that indicator. For fully immunized status, you can again take a look at the coverage map of fully immunized status, how that breaks down into equity on the maps to see where there are overlaps regionally within the country. And finally, you can again break that down into its component parts to take a look at how each of those different types of contributors are factoring into what we measure. And we again see that maternal education, not surprisingly, is a leading cause or a leading associative factor with the inequity that we're viewing. The second case study that I want to highlight here is from Peking University with collaborators Haijun Zhang, Zhao Zhenlai, Haonan Zhang, and Hai Fang, who's the PI at Peking University, in charge of this work and the adaptation of the toolkit for the setting in China. And the team at Peking University has accessed data from several sources to examine differences in coverage and equity for vaccines included or not included in the National Immunization Program. And so the sources of data included data from the Chinese CDC and data compiled by Peking University on vaccine coverage at the local level. And so the purpose there is to examine both the degree of inequity for non-immunization program vaccines compared with immunization program vaccines, and also how that inequality, the factors contributing to that inequality differ across those vaccines. In Bangladesh, you can see our team there, including the local PI, Hasim Udin, as well as Zahid Hassan, Zaran Janat, Hamadas, Wazir Ali, Arif Ahmed, and Sayam Ahmed. And they're with the Institute, the ICDDRB in Bangladesh. And there, the goal is to collect data on epi vaccine coverage in urban and slum and non-slum settings, as well as rural settings around Dhaka, Chattagam, and Brahmanbaria in Bangladesh. And the purpose there is because a lot of the national studies, in particular DHS's, but some other studies, tend to undersample from urban slum settings. And so there's a need to do sort of a deep dive assessment with primary data to understand the vaccination status in detail in slum settings, which may be quite large in urban areas. And so this is meant to be a deep dive into that to see if we're appropriately sampling from slums in terms of the data that we're using at the national level. And if we did appropriately sample, would we be getting the same degree of inequity that we would expect? We're also collecting data there on cost of illness. So there will be coming over the summer, the adaptation of this toolkit to look at the distribution and inequality and cost of illness resulting from vaccine preventable disease, rather than just the coverage of the vaccines associated with each disease. And we can control for different things like additional impact of routine vaccination uptake and access to healthcare within this study, because we have done facility-based surveys that can link directly with the individual level data. The final case study that I'm going to highlight before we move on to our colleagues from Uganda is an adaptation of this toolkit into the maternal and child healthcare space, so beyond just the vaccination space. And we hope that's the methodologies that underlie this, which I presented in very, very high detail in another webinar, and which are linked to some of the packages of materials that'll be sent out after this. But they've mostly been adapted for vaccines, but we hope that the same approach can be used to measure inequity in all different types of outcomes that are relevant to universal health coverage or relevant to policymaking. The methods are in a way that can be standardized across different types of outputs and outcomes. And so we hope that this can be adapted into other settings. And with our colleagues in India at the Postgraduate Institute of Medical Education and Research in Chandigarh, and at the All India Institute of Medical Sciences in Kalyani, we've been working on adapting this to other maternal and child health outcomes. So Dr. Madhu Gupta, Nimran Kaur, Paramita Sengupta, and Jitendra Maji, along with our colleagues at Johns Hopkins through the Maternal and Child Health Center, India. And so the maternal child health outcomes we've been looking at are maternal health services that are accessed, like antenatal care visits, facility-based delivery, postnatal care visits used by respondents, child preventative care and routine services, so whether or not they seek care for different types of illness that arise and whether or not, of course, they're vaccinated, and child treatment of disease. So did you access healthcare in response to a particular illness? We've also taken a look at COVID-19 vaccination status among individuals in those populations to determine sources of inequality and inequity in vaccine access for COVID-19. And so these will all be forthcoming later on over the summer to show the adaptation of this toolkit into outcomes other than just purely vaccination. And our goal for the selected maternal and child health comes here to show the scale of inequity and how that varies across pediatric versus maternal outcomes, as well as are there different drivers and different things that are associated with these levels of inequity, because maybe responding to both of these types of inequity should be done in different ways. So an example from some of the preliminary data in that setting shows sort of some very stark differences in how things break down in terms of the associated factors. So you can see here that we have a concentration index of 0.15. This is the composite verse concentration index. I haven't talked much about interpreting that. It's meant to be a proxy for how much would need to be transferred in terms of the outcome from the most advantaged 50% to the least advantaged 50% in order to obtain inequality. But we like to think of it more as a tracking and monitoring metric. So further away from zero is worse, that's more inequity that's observed. And improvements over time as that goes closer to zero will represent progress towards inequity. For interpretation for policymakers, we present the absolute gap, which is the coverage difference between those two groups. And that can be interpreted directly as there is a 20% coverage gap between the top and the bottom groups. The decomposition for maternal status here you can see are quite different. So there's a very strong difference between what we're seeing in terms of the correlates with inequity for maternal health checkups at 2 months versus COVID-19 vaccination status. You see that urban-rural eats up a large majority of the variation in inequity that's observed for whether or not the mother gets a health checkup at 2 months, but COVID-19 vaccination status for mothers is driven primarily by education level, as well as the influence of socioeconomic status, with urban and rural factoring in less than 10% compared to 50% of inequity. So just to show how we can see some of the differences and correlates with the observed inequity to see what might be the source of the problem. And this can be a useful tool for helping policymakers do deeper dives to figure out what the causal pathways are between some of these things and the outcome. And so this is meant to point people in sort of a direction to go in when thinking about ways to improve the situation. And you can see some of the specific things that we've added in the India context for the tool, and it's possible to add any different types of things that one would want to see a breakdown by in any setting, so long as there's data on it. So with that said, I will pass on to our next speaker to talk a bit about the in detail the work that's been done in Uganda.
Many thanks, Bryan, and it's my pleasure to share with you our experiences from our work that we've done in Uganda on this project. Anthony Sebagereka is my name, and this is the team that we've been closely working with on this project. Yeah, so specifically, we want to share our experiences regarding use of the VAS full application of the VAS toolkit in assessing and tracking equity in vaccine coverage. And for the purpose of this webinar, we want to focus on three main components. That's the DPT3, MCV1, and fully immunized for age. We also want to share some insights on the impact of the maternal education on vaccine uptake, and also want to share some updates regarding application of the VAS tool to be able to track progress in immunization coverage and equity, and specifically use the Uganda Demographic and Health Survey spanning from the year 2000 to 2016. Yeah, so we also shall eventually share some insights regarding stakeholder engagement and involvement, specifically sharing experiences on how we've engaged institutionalize the vast toolkit into the equity assessments and analysis and coverage into the programming and activities that that they are currently doing. And my colleague Elizabeth will be delivering this later on a couple of slides. So jumping into these outputs, specifically with regard to the DPT outputs, applying the Uganda Demographic Health Survey of 2016, we can see that there are some variations regarding DPT3 vaccination coverage compared to the equity assessment. And specifically for some regions, you can see that there are some regions, example, like the Ankole region, which is second last towards the bottom, had fairly good coverage, but then had fairly large extent of inequity in vaccine coverage. So we're not reaching all the desired people that are meant to reach using this particular antigen DPT3. But also the pie, the donut that we see down there, specifically highlights the areas which are really contributing to or responsible for the inequity. And largely, this is maternal education, which we shall speak more to in a moment, and as well as the impact of the district, the variations in district coverage and equity district level. Yeah, so this is these are outputs for MCV1, and still showing the actually variations by region in terms of coverage and equity. And we also, just demonstrates that actually whereas you can have very good equity coverage in one region, you can actually, some region, in that same region can actually have high inequity indices and vice versa. So this helps, as Bryan said, this helps the stakeholders and policymakers to give a detailed inquiry into what could be responsible for these inequities and actually be able to have focused programming and interventions therein. And also the donut down at the bottom also re-emphasizes that maternal education has a substantial role to play in terms of defining inequities. And this was quite consistent across most of the other antigens, but also across regions. Even for some regions, defining even over 50% of the variation. So regarding, we also assessed for vaccine coverage and equity for fully immunized children for age. And we see a fairly different picture, specifically for the coverage outputs. We see that there are several regions that had quite low coverage. Those are the ones in the red color in the heat map. But regarding equity, we saw that some of the regions that actually had low coverage had fairly better equity indices. So it means that some of the low resources, few resources that actually are given actually put fairly better use. But for some of the regions, we actually saw, like the West Nile on the top left corner of the map of Uganda, you can see that whereas the West Nile region on top left, upper left corner had very good coverage, but it had fairly low indices for equity. So basically, it lists again some inquiry to see how and what issues could be responsible for that, but also to be able to have focused interventions. So specifically speaking more to the role of maternal education, we see that maternal education had a substantial role to play in terms of defining or contributing or explaining inequity in vaccine coverage, and this is an important attribute in terms of if it's an intervention that has to target aspects of maternal education. I think those would be quite significant in terms of being able to improve vaccine inequity across the selected regions. The table below also just gives a distribution of the different percentage portions of coverage across the different antigens. On the immunization schedule, we see that BCG has the highest as expected, but I think what's quite interesting here is that we have MCV, MCV1, which is actually higher than the BCV3 and DPT3. So, and some of the discussions with the policymakers are quite insightful in terms of what could have explained this, but also we also assess whether maternal education for each of the antigens could have been a dominant factor in terms of explaining the variations in inequity. And we see that for BCG, DPT, as well as PCV and MCV, maternal education was really a dominant factor. And so it re-emphasizes the contribution of maternal education in being able to explain or contribute to inequity that we are seeing across regions and districts. It was only for polio and overall fully immunization status that where we didn't see maternal education being the dominant factor here. Okay. So here in this slide, we also demonstrate variations in coverage as well as equity over the years. So specifically using the UDHS data from 2000 to the year 2016. So basically there were 4 data points. And we see that for BCG, we had fairly good gradual improvement for both coverage and equity. However, we see a different picture for polio, specifically for polio 3, where we seem to see a slight decline in coverage, but also a kind of a zigzag picture in both coverage and equity between the year 2011 and 16. And there are a lot of things in terms of programming that happened in between there that could have led to these variations, but also it paints a picture that not all, that variations in equity actually also affect coverage for some antigens, but also that can also happen vice versa. And this has a lot of programmatic implication in terms of when you're setting a policy stage, but also the decisions that are done at policy level. We also seem to see a similar picture of variations for full immunized status, but as well as the DPT3. So we just want to highlight that gradual change over time and how equity and coverage actually indeed do change over the years, and how immunization policies actually do affect these concurrently. So I will want to pass over to my colleague, Elizabeth, to speak more to stakeholder engagement, the approaches that we've used, and also some particular implications of the first toolkit in terms of application at national level. Over to you, Elizabeth.
Thank you, Anthony, for that. So when developing toolkits, it's always important to get the perception of stakeholders and involve them so that in the development process, if possible, you're able to address your concerns. So while the VAS toolkit was being developed, that was done. And we had a meeting in which we're discussing and to which we invited some of the stakeholders to gauge their interest in the toolkit. That slide there just represents some of the stakeholders, and broadly looking at the people who attended, we had several officials from the Ministry of Health. Initially, because the work has been focusing on immunization, we had representation from those in our immunization program, but we also had representation from those who are responsible for planning within the Ministry of Health. We also had institutions and that are responsible for generating national level statistics. A lot of the surveys that are done in the country are done by the Uganda Bureau of Statistics. The Resource Center at the Ministry of Health is responsible for collecting information from the different health facilities. We also had a number of non-governmental organizations and of course, academic institutions. We can move on to the next slide. Sharing some of their perceptions, we were pleased to note that the response and the interest was high, and the people's perceptions about the tool was generally positive. And that is because of what you have already had presented about the tool. When people develop policies or when they're implementing, they often face a challenge trying to identify the factors that are contributing, for example, to inequity, the factors that may be contributing to people not utilizing the services, and specific data that can point to such factors is often in short supply. And so the stakeholders felt that the VAS tool would particularly be useful for guiding programming decisions and for helping them put in place interventions that can actually reduce existing inequities. And it would also certainly be able to help them measure progress in terms of whether the interventions that they have put in place are changing or not. The fact that the VAS tool can be applied across several different services was also pleasing to them. And it was presented, Bryan already mentioned the fact that we have started by implementing this in immunization, but its application can go beyond that, which means several different sectors within the country can be able to utilize the tool. In terms of how they felt they'll be able to use the tool, we usually have evaluation programs being carried out at different levels. The Ministry of Health itself, whenever it develops a strategic plan, midway through the plan and at the end of the plan, it tends to evaluate the different interventions. And so they felt it would be particularly useful for helping the Ministry of Health evaluate its strategic plans. But different organizations also carry out evaluation surveys when they carry out different projects. And so that was also mentioned as a place where this tool would be particularly useful. The different programs also collect information that can be analyzed using the VAS tool. Performance reviews are also done. Our Ministry of Health does an annual performance review. And so once again, this is a tool that will enable the country to be able to dig deeper into the factors that contribute to inequity and influence the performance of different regions. And you already heard about some of those reflections when Anthony was presenting. The Uganda Demographic Health Survey is done regularly in the country, and they usually do a deep dive analysis to try and understand the distribution of some of the variables and the factors that contribute to the pictures that is seen. And so again, stakeholders from the Uganda Bureau of Statistics felt that this will be a useful tool for them to be able to understand the variations that they see across regions, across different socioeconomic status. We also think that the tool will particularly be useful for students who undertake dissertation research at the university level, and this will be useful both for the master's student and for those who are doing their PhDs as well. The stakeholders also shared some of the challenges that they foresee and some of the concerns that they have. They noted that indeed the tool is user-friendly and can allow us to do a great deal of analysis. However, within the country, often we don't have individual level data being collected at lower level units. You know, health facilities may not have that kind of individual level data. Sometimes we do surveys, for example, we may do a coverage survey after an immunization campaign, but it may not have the set of variables that would help us to be able to understand inequities. So the issue of collection of a limited set of variables was a challenge that they could foresee. Our systems are also largely paper-based. The aspects that are electronic usually have aggregated data, but individual patient level information that would be useful for this kind of analysis is often paper-based, and that was also seen as a limitation. And then to interpret the information and to be able to understand, you know, why is probably a region like Kigezi doing better, or why did you have, you know, better statistics in Karamoja or poorer statistics in another part of the region? Looking at the example of immunization, at times you find that there are supply side factors, you know, perhaps related to stockouts in vaccines, perhaps related to the immunization outreaches that may not have happened for one reason or another. So you find that you need supply side data, you need contextual information that can help you to be able to explain the results that are seen. Sometimes this information is available, sometimes that kind of contextual information is not available. And so the message they were giving is that whenever dissemination is happening, we need to try and ensure that this kind of supply side and contextual information is also collected. Then some people may not be conversant with R and may face some challenges in terms of utilizing the tool. That was also noted. They also noted that not all policymakers or implementers may be well versed with the interpretation of some of the statistics. And so they were emphasizing the fact that this needs to be presented in a simple and straightforward manner to ensure that when they get the results, they're able to use them. If they generate them themselves, they're able to use them as well. So as we mentioned earlier, they indeed noted that this toolkit can help to reveal inequities that are contributed to by other factors beyond socioeconomic status. It's also able to reveal and examine the extent to which different factors contribute. You know, a case in point is when we're looking at issues to do with maternal education. And so that will be particularly helpful in helping the country respond to those issues. The fact that you're also able to do this kind of analysis over time allows you to be able to assess the progress that you have made over time. Often changes are made in terms of the policies, in terms of the way that services are distributed, and so that is able to help. And also, I mentioned, the fact that people wanted to be able to interpret the metrics, and already this was noted during the development of the tool, and so there are plans to ensure that whatever outputs are out can be easily presented, and Gatien will be talking a little bit more about that. The fact that the toolkit is available in open access, it's free to use, it can be customized and utilized in different settings, again, is very important, especially in low-income countries like ours, because it means that people can be able to access this. Policymakers and implementers can very easily do that. The fact that it can also be adapted to new settings, the fact that you can use it for different conditions also makes this a tool that you can use across a wider set of programs. So those are the reflections that were coming out from Uganda, and I'll hand over now to Gatien.
Thank you very much, Elizabeth, Anthony, and Bryan. I want to talk a little bit about the resources that you will have available to you if you want to give a try to the Verse Equity Toolkit to analyze DHS data. Now, we initially planned to have a full demonstration happening of the tool in front of you. Ours sometimes can be a bit finicky when we share our screen, so we decided instead that it may be better if you can watch this video that will be linked here in your own time. It is very well detailed. It will have subtitles, and it will be part of a post-webinar folio that we will provide you with. We will also release very soon a course, a Verse Equity course that will be hosted by the Maternal and Child Health Initiative here at IVAC. This course will really give you everything you need to interpret, to approach equity from the Verse angle, multifaceted, using a composite ranking index rather than based on wealth only, how to interpret the results from it, what are the different outputs that are created, how to wrangle these outputs to make different presentations or make a case focus on specific vaccines or specific vaccine issues. While this course is, of course, going to talk a bit about the program itself, it is not a coding course. You will not need to know R profusely. You will not need to really go deep into it. You will have the option to, but this course is really designed to use the outputs at a higher level for interpretation, for follow-up, and to integrate this in government or non-government assessments for equity. There is the option to dig deeper, and we will provide a snapshot of the two programs that are actually going to be available to you. One which analyzes DHS data, which allows you to simply enter the country, the year, and the vaccines you're interested in, and then generate results for that country. And so that's the resources we'll really provide you at the end of this webinar, and you can run it as soon as our session is over. The second program will be just the core Verse program, which will allow you to edit it to be amenable to other data sets than the DHS. This is still under development. We have the core program, of course, but we're trying to make it in an easy way for you to customize it. So that's something that we will be also releasing on the public platform pretty soon. So the course will touch on this, will allow you to touch at the coding, to run the tool yourself if you want to, but the main target, the main content of the course, you can complete it if you are simply able to interpret those figures and equity measures. We know in research that these concentration index and quantitative equity measures are famously difficult to compare or to use for policy making to translate to this. So this tool is really an effort to do that, and the course will help with this. It will be released within the next 2 weeks. And finally, at the end of this webinar, you're going to have access to a survey. We would love to know what you thought. If you have any comments, suggestions, requests, issues, we'd love to hear from you. At the end of this folio, but also here in the presentation, at the end of this survey, you will have a link to this folio. And so this folio will include the demo video. There is also a link to Panopto if you want to simply stream it, so you do not have to download it. There will be a list of countries and years for which we've tested the tool, and there is DHS data publicly available for it. The data is clean. The tool takes care of any additional issues that may arise with specific DHS's data sets. And so you can run the tool on these countries without a hitch. And finally, there will be also the slide deck that you've been presented today, and that contains all the content from this launch as well. And so we organized it in a series of very neat links for you to navigate. Of course, if you have any issues, don't hesitate to contact us. And there is also a link for this in the folio. Great. I will pass it on to Bryan to discuss what's next for the Verse Equity Toolkit.
Thanks, everyone. So yeah, I'm going to talk a little bit about what's coming up next for this and how some of you might be involved if you're interested. So I just want to highlight again, the purpose of the Verse Equity Toolkit is to allow a consistent metric that can hold programs accountable to targets and monitor progress towards reducing inequity nationally and at the subnational level over time, and doing so in a way that can encompass more determinants of inequity than just one or two, and not have so many disparate measures, like needing to take a look at the urban-rural ratio and the sex ratio and the gender gap and the socioeconomic concentration index all together, and then try and determine the relative importance of each in terms of holistically reducing equity. This simplifies that process quite a bit. We're hoping that this can be used to identify changes and contributors to inequity or inequality over time by the breakdowns that we've shown through the decomposition, and give an idea of where some of the correlates of that inequity are, and perhaps doing deeper dives to target policy towards alleviating those correlates, or to just getting an idea of what the landscape of the correlates looks like and how that might change over time in a specific setting. Another application is through the equity efficiency planes produced to be able to assess the trade-offs between coverage and equity and whether or not those exist, and if they do, where they exist, and sort of why areas or sub-regions that are obtaining similar levels of coverage are doing so at the expense of equity or along with improving equity. So important things to compare over time and across space. And finally, to demonstrate empirically the extent to which reductions in sort of one dimension of inequity or inequality impact the total score. So whether drastic improvements in sex-based inequity, how much that's doing to alleviate the overall inequity that we're observing. So this is helpful to be able to compare policies that target different features of inequity and how they're contributing holistically to the overall situation in a specific setting. And we're particularly interested in examining some of the following topics going forward. So examining the coverage and equity and prevalence, healthcare access and vaccination for COVID-19 and COVID-19 vaccine, allowing the coverage and equity in primary healthcare services to be examined in low income settings. So other things that are contributing to healthcare, things that may be not necessarily measured in a DHS, but could be measured in a DHS, other different types of outcomes that could be examined. And the use of the Verse Equity Toolkit to track and assess health outcomes based on government priorities. So we're really interested in how this can complement different priorities that the different settings have, and how this data can be incorporated. So one area we're thinking about is, if you have grants or if you have programs meant to reduce inequity, perhaps the VERSE indicator could be one of the measures that is utilized to track progress towards those investments to see how they're doing across the span of different types of inequity. So some things that are, before I move on to the last slide, some things that are planned going forward is right now the tool exists in the detailed version that Gassian shared. We were intending to go over it, but we really wanted to be careful to show all of the different features, because there are features built into the toolkit that are specific probably to academic researchers, like being able to pull out all of the different features of the different indicators and all the different types of statistics associated with them, and the higher level things and the graphics that are useful mostly towards decision makers and policymakers who kind of want a high level picture of everything. We have the ability to pull out both. They're all stored in different parts of the outputs, and you can call them up within the R framework, and they're stored in standard tables that are already produced. So all of that's there, and it took a long time to kind of go through that bit by bit, which is why that we recorded that as a separate presentation. But we also have the intention to expand this into a web-based application. So if you have no familiarity with R whatsoever, you can use this. You don't need any familiarity with R to run the code. It's like a package that's set up that you can link from our GitHub and get. And use and link directly with the DHS. If you have your own data set, you need to understand how to upload that data set, and we have guidance on that. But for linking with the DHS, you really don't need to know how to use R at all to utilize this, but we do want to make this as simple as possible and accessible to many. So we're working on converting this to a web-based application as well, where you can upload a data file or link to the DHS data sets that we have access to through our study, and be able to sort of produce these numbers as well. So there's a lot of that coming forward for those who are not keen on utilizing the R-based package that we currently have, but we wanted to get this out there for researchers and for those who are interested and have the ability to play around in R a little bit to be able to utilize these methodologies and produce some of these outcomes. So all of that is coming later on this year, along with specific results from the case studies, where we'll be publishing briefs on our website, which Gassian will share with you right after the end of the webinar. And you can follow on sort of what's being produced in this and reach out to us if you are interested in collaborating or have any potential use cases that you want to explore for the toolkit. So with that, I just wanted to give a big thanks. This project was funded by the Bill and Melinda Gates Foundation, and we're very grateful for their support and for all of our many dedicated collaborators and partners who've been mentioned over the course of this webinar, in all of the settings that we've been working in. It's been a pleasure to work with you all. And so finally, we can open it up to discussion and questions. Gassian.
Absolutely. Thank you very much, Bryan, for this. So we have collected quite a few questions in the Q&A, and I know that, Bryan, you were able to answer quite a few as well. What I'm going to do is I've assembled a few into questions for the panelists, for Bryan, Elizabeth, and Anthony. But before I move on to that, the QR code that you are seeing on your screen right now, if you scan it with your phone, it takes you to a small survey that basically is a way to contact us if you wanted to engage with us, if you had the idea of a data set that you'd like to apply the VERSE tool onto. This gives you a form to provide some information about this, and we will contact you to see how we can help with this. All the material, the course, the programs, everything will be in open access. We strongly believe in it and think that it is one of the strengths of this tool, is that it can be modified and used by the community of users in different settings and country to tackle many situations. So what I will do is, we have no more content for now, it's just a Q&A. If you are leaving, please take some time to answer the post-webinar survey, at the very end of which you will have a link to the folio. So the first questions, and maybe that is more for Bryan, is a methodological question around the choice of the concentration index between choosing to go with the Wagstaff concentration index or the Iriger's correction. Could you talk a bit about it?
Yeah, so we're being agnostic with respect to what the end user chooses to use. There's trade-offs and rationales for using either. And we present both in the toolkit. You can do this decomposition of both. We also have I didn't mention it right here, but we also have another index that's produced, a horizontal inequality index, which is a function of the concentration index as well, which you can pull out of this. And really the change that we're making is the ranking criteria for that. Typically it's, individuals ranked from best to worst off in terms of socioeconomic status or income, but here we're using this composite metric, which is based off sort of propensity for fair or unfair access to the vaccination in the setting, taking into account all of the different potential determinants that we have in the model for the countries in the base case. So the outcome is your choice of what one wants to present. There's, the standard interpretations apply to either. We recommend that users of this just state specifically in anything that they release utilizing the toolkit, which specific verse output they're using. And the purpose of that is to allow it to be compared appropriately across other settings utilizing the tool, as well as to compare with sort of other types of concentration indices appropriately. So if you wanted to compare it with the wealth-based standard concentration index, that was done for that outcome as well, like we did in India and a number of other countries, you could do so with the appropriate one. You don't want to be comparing a Wagstaff style index to an Iriger's index in terms of level. That doesn't make any sense. So just call it out. We tend to recommend in terms of policy presentation to, if the good thing about concentration indices is they measure the whole distribution across all levels of disadvantage well. And so they're really good for measuring and tracking over time and monitoring progress. But in terms of translating qualitatively to decision makers who don't have maybe a solid understanding of what that means, the absolute equity gap is very easily translatable. It's only going to take a look at the most and least disadvantaged groups and not account for the variation in between, but it's just measured in terms of the outcomes of coverage. So we recommend typically presenting those absolute equity gaps from this tool alongside the concentration index, which is in itself a better measure. But the absolute equity index will allow you to interpret with respect to levels of coverage, for example. So those are the reasons we include all of these things for different audiences. No one is, one probably would not use all of them.
Thank you very much, Bryan. And actually continuing on these measures for concentration index and otherwise, we've talked a bit about comparison at the subnational level, so within a country. What would you say about comparisons between countries with these indicators?
Regarding comparisons between countries and within countries?
Yes. So we talked a bit about within country at the subnational level, but what about between countries? Can we compare the level of equity in different countries using the same measures, and how would that work?
Yeah, so the concentration index outputs for this are standardized so you can compare them across really any setting. So just like, a Gini coefficient, for example, we're having percent shares against percent shares. So the measure that's actually produced through that is comparable across setting, as long as the coverage for the absolute equity gap, as long as the outcome you're looking at is the same. So coverage levels, differences for the vaccine, you can compare across anything else that uses the outcome. The nice thing about the concentration index too is that you can compare it to other outcomes. So if you wanted to compare inequity in antenatal care visits with inequity in pediatric immunization for measles, you could compare those two concentration indices and they'd be directly comparable to one another across countries, across time, between subnational units within a country. You can compare those two things. Using the absolute equity gap, you can't compare those two things because they're measured on different scales, right? They're measured on access to maternal health coverage versus access to coverage. So they're a little different in terms of interpretation, but the concentration indices can be compared directly as a measure across any of the different types of outcomes as well as settings and time.
Okay, thank you very much, Bryan. And so one question that a few questions were also around how do we use these estimates? And this is a question maybe as well for Elizabeth and Anthony. How would you use these insights that you're getting from the VERSE tool to target a population at greatest risk in a country?
So I think that there are different approaches to doing this, and I saw a comment in the chat. Can you hear me, Gassian? Do I have a lot of feedback?
I can hear you pretty well. It's good on my side.
Okay, just making sure. So in terms of targeting resources, we believe that this tool is most useful in terms of determining sort of broad areas of contribution and where sources of the problem may exist. So this is not a causal estimate. These are not causal models. This is really like the creation of a metric to use to then run causal analyses on. So one could utilize this metric over time across a bunch of countries and run more causal type assessments, utilizing this as an outcome or an output subnationally. Our breakdowns are really just meant to give an idea of how utilizing the same approach and the same methodology and the same data set over time, the contributing factors that influence variation change or don't change with respect to time or with respect to the specific vaccine in a country. So they're just giving a snapshot idea of what the landscape looks like. And policymakers can utilize that to do deeper dives to see why is maternal education so strongly associated with inequity and to figure that out. Or if one was considering, for example, a conditional cash transfer that's attached to a health outcome as a condition or a healthcare utilization as a condition. Maybe if you see that maternal education level or sex of the child is the leading determinant for access to coverage, maybe that policy is not the best idea because it doesn't seem to be an income issue. And so these are the ways that we think that it can be used in terms of thinking about that. We don't want it to be used as sort of causal assessment. We want the metric to be used as an input into future causal assessments, but the toolkit is not meant to be a causal assessment in and of itself.
Thank you very much, Bryan. I don't know if Anthony and Elizabeth, to give you a chance on this, if you've heard in your discussion with at the policy level, really you were involved with district health officers and biostatisticians at every level at the Ministry of Health in your work in every day. When you see those indicators, those economic equity and coverage indicators brought in together, especially with the trade-offs we've seen for Uganda, did you get any feedback on that? What do you feel that a way forward on how to target specific population seems to come naturally? Like what discussions does this provoke?
Maybe I could go first, Anthony, here. So yeah, I think it was quite insightful in terms of eliciting feedback from the stakeholders. I think what was one of the areas where interest was really, really high was being able to use this tool at subnational level. So being able to pick the bit of detail of inequity at subnational level, either within a particular district or within a particular area of jurisdictional facility or something like that, because that's where actual intervention can happen to really bridge the inequity gap. Over and beyond eliciting, additional inquiry. So also what was quite important or relevant was being able to be able to track trends in equity compared to coverage over time. And this can be able to also give a profile of what changes in inequity and coverage over time. And it can also be able to profile how changes in coverage and equity within particular districts over time. So you can be able to tell that there are problems in this particular district or in this particular region or in this particular area over time, and hence it needs a particular package intervention, rather than a one-size-fits-it-all in a given jurisdiction.
Thank you, Gaten, for that question. So again, the reflections that we had with the policy makers is aligned to what Bryan was saying about this being a tool that begins to point out problem areas more specifically. For instance, one of the things that attracted attention, when you look out the dropout rate and you look at the proportion of children who get, for example, DPT1 and DPT3, you note that those who are able to access the health system at the time of birth, compared to those who are able to get it, later at 14 weeks, decreases. When indicating that, people may initially be able to make contact with the health system when they're having their babies, but once they get back home, there are challenges that they face in terms of being able to access services. So that points out to the policymakers the importance of continuing to understand the challenges that are still persisting despite the interventions that have been put in place. Another issue that was important, when you look at differences between regions, the policymakers realize that immunization services are set up in a similar way across the countries. You're not supposed to pay anything when you go for the service. You should be able to get it daily. If you go there, different facilities should be doing outreaches to get the services closer to the people. But when you see these differences between regions, then as programmers, you realize that there are certain factors that are playing out better in certain regions. And so issues to do with the kind of leadership in the facilities and the way services are offered and how much attention is paid to doing what should be done becomes emphasized, and the importance of oversight and the district health teams overseeing what is happening in their districts becomes particularly important. So it also highlights some of the challenges that places that have that are maybe located in mountainous regions, places that are located on islands. When you see coverage low in such places, again, it emphasizes the fact that more needs to be done to provide services to such places. Again, one of the trade-offs, lastly, that keeps coming up is the issue of missed opportunities, because whenever a child engages with the health system and they're not immunized, ideally they should get an opportunity to immunize. But then, if you open a vial that should serve several children and you open it for just this one child, there is also wastage that takes place. So that trade-off between trying to increase access and then also trying to be efficient in terms of how you're using your vaccines, for example, becomes an issue again for discussion. So it throws out a number of very practical things that attention has to be paid to and that could improve access for these different antigens that we see.
Thank you very much. And this is true. The interesting part when you look at the decomposition pie is what we could attribute potentially, again, no causality, but the purely descriptive to supply side constraints. And we've seen that in the case for Uganda, where in provinces, or at least in regions where you had a lot of islands, that supply was more constrained there. But one thing that also appeared shocking in some of the results in the decomposition, with the decomposition factor, it's the large influence that maternal education has played on vaccine outcomes. And we've had a few questions about this effect of maternal education. You've tackled it in your presentation, and I wonder if, if there's an effort that could be made in detailing this maternal education factor. Maybe it is really about maternal access to postnatal care. Maybe it's other things. What could we say about that?
Just again, reflections. I think, like you said, the fact that maternal education plays such a big role highlights the fact that we need to understand this further. When you look at, first of all, the factors that contribute to maternal education or that affect maternal education, issues related to teenage pregnancy are one of the challenges we have. We have a very high teenage pregnancy rate at almost 25%. Issues related to early marriage, issues related to poverty. So these are some of the things that sometimes make girls drop out of school. And having dropped out of school, it's possible that some of those problems persist. Teenage mothers who have not completed their education may not be able to appreciate the importance of giving their child a vaccine. So perhaps after the child gets a first dose at birth, they may not appreciate the fact that they need to ensure they get all the antigens. They may be facing challenges in terms of being able to go back to the facility. When we're doing work among mothers who are disabled, who often also don't complete their education. Again, you may find that some of these mothers may also have other problems like physical disability that is linked to their educational status. So really, in summary, maternal education, yes, but for which mothers is this a huge factor, is something that then requires further study, so that the interventions can particularly target those groups. Yeah.
Thank you very much, Elizabeth. And with this, we are right on time. So I want to conclude by saying that you will have access to all the material that is provided through this launch, including the recording of this session in the post-webinar folio. To access it, we provided the link a bit earlier, but the easiest way is to fill out this post-webinar survey that you will have as soon as you log off. We are more than happy to discuss with you. We've seen questions about bringing ideas from your own projects. We'd love to discuss this. Everything is in open access, so you can also see it in advance before you contact us. Otherwise, use this QR code, use this form called Use Your Data that is on immunizationeconomics.org. The link was provided in the chat, and we will be happy to examine what you are proposing. On this, I'd like to thank again very much the Bill and Melinda Gates Foundation for funding this project and allowing this to move forward. This is really a fantastic initiative. And thank you to all the participants that joined in today. We had 260 people registered for this talk today. I would like to thank, of course, our speakers, Dr. Bryan Patenaude, Dr. Elizabeth Ekirapa Kiracho, and Mr. Anthony Sebagereka, as well as on our side, Mr. Joshua Mack and Mr. Andrew Lan, who helped make this webinar possible and answer questions. If you have more questions that are not answered here, please contact us. We'll be more than happy to connect with you. On this, thank you all very much.